Morning. Thank you, everyone, for showing up. Appreciate it. Thank you for Dr. Jana taking that time to talk to us about total joints. It's very interesting stuff, and hopefully we can implement more efficiency on that end. That's a big topic in the orthopedic world. I've been asked to come back. I've given this talk a couple of years ago, and I guess due to popular demand, they wanted foot and ankle team to come back. So here I am. There's a couple of ways we can do this lecture. Number one, I can go through my spiel. I've got all the slides. I'm going to talk about the foot and ankle, some anatomy, and then some injuries. But what I'd really like to do is I'd like to go through about half of this and then open it up to the field. I'd love it if you guys ask questions. I think that's, for me, that's the best way to learn, is that that interaction between you guys and answer the questions of what you're interested in, as opposed to me just up here blabbing away. So please feel free to ask questions. So I'm part of MD West One. We have 4 locations here in Omaha, and it'd be sad if I didn't, put in a shameless plug for our group up here. So we just built a new office across the street. It's beautiful. It's fantastic. Eventually, maybe some surgery over there, but right now, it's just clinic. We have a hospital and then also a clinic down in Farnham. And then we work out of Jenny Evanston. We work out of Fremont Hospital, and then Methodist Millard Clinic as well. So we're kind of all over Omaha. And it's been a great practice to be part of. I'm personally an Omaha native. Grew up in Omaha, went to Creighton Prep, went to Creighton University and the Creighton Medical School. So I always say that I've given the Jesuits a lot of beer money in my day. And so after med school, I finally got out. I went to KU down in Kansas City, which is fantastic. Did 5 years of residency down there and loved it. And then was very lucky and honored to get a fellowship in Boise, Idaho, with a man named Michael Coughlin. And Michael Coughlin, I don't know if anyone knows him or met him, but he's a wonderful man. He's wrote the book on foot and ankle. He's now retired, but he was the kind of the pinnacle of the foot and ankle world when I was going through training, and just a wonderful experience up there. And so I felt like I got really good training up there. And then I came back to Omaha, and I worked for Methodist Hospital for about 10 years. And then we joined MD West One in 2020, right when the pandemic hit. So that was a lot of fun. But why foot and ankle, right? It's disgusting. Who wants to look at feet all day? That's a very legitimate question, and I still kind of question at times. Total joint surgeons, they got it great. All they do is they do 2 surgeries, they drive off in their Ferrari, they go to their yacht, and they sail off to the Maldives, and they got it great. Why the heck would you want to be around stinky feet all day? Well, it's the challenge, right? The foot is such a complex anatomical structure. There's 26 bones of the foot. That's a quarter of all the bones in the entire body, right? Think about how complex that is. 33 separate joints in that small little structure. Muscles, tendons, ligaments. I mean, look at the bottom left slide. Look at how fine the print is. You can tell that there's a lot going on by how small the print is. It's just very, very complex. It moves in a very 3-dimensional structure. Everything is dependent on everything else around it. It's just, in my opinion, an amazing part of human anatomy. And that's what really got me interested in it in the first place. It's a combination of surgery. You can do really big surgeries, right? Big physical things, kind of like total joints and things like that. And then there's really, more intricate, kind of fine detail work, nerve repairs, artery repairs, very nuanced things as well. So you get this nice scope of all different aspects of surgery, which to me was, again, very appealing. So the foot, it's a very 3D structure, as I mentioned. The arch itself is always referenced to the Roman arch. And as you see in the arch, the key to that structure is the keystone, right? The stone on the very top. If that stone on the top were to crack, if that stone were to fall, then the entire arch falls down with it. And so the foot is very similar, right? You are putting a tremendous amount of stress through the middle of that foot. And of course, the middle of that foot's very integral to the success of that structure. Range of motion, it's very complex. The ankle goes up and down, obviously, dorsiflexion and plantar flexion, anywhere from 0 to even up to 60 degrees. And dorsiflexion is 20 degrees up. And then you have the subtalar joint, which is that side-to-side motion. And so that entire complex is not one uniplanar structure. It's multiple planes of motion. Again, very complex. And then you add deformity on top of that, and it gets even more complex. You have toe range of motion. Toes go up quite a bit. They go down a little bit. There's 3 different joints in the toe, so there's a lot of motion there. So you have all these factors working together all at the same time. And again, it's enough to make your head explode, right? It's a lot. But that's part of the allure. That's why I love it. So then you take, let's say, the foot and ankle, which obviously is its own entity, and then you look at what's on top of that foot and ankle, right? So let's look at this picture on the far left. So that patient's right knee is in a tremendous amount of what we call valgus. Well, look at what it does to the ankle, right? That leg is sticking out to the side so much that that ankle has to adjust and, in essence, deform itself in order to get itself flat to the ground. Well, you can imagine that that particular situation, that's not good for the foot or the ankle, right? That is going to cause problems long-term wise. So oftentimes when you're looking at the foot and ankle, you can't just be staring at that one structure. You got to take it into account the entire picture. What's going on up top? You know, is it the knee? Is it the hip? Is it the spine? All that comes into play to influence what you're going to do down in the foot and ankle. And not even that, is this is oftentimes what else is above, right? You know, you talk about all the forces that are going through the ankle joint. Well, in this in particular country, we have a significant obesity problem. And those joints are undergoing a tremendous amount of stress, a tremendous amount of pressure, putting so much strain through it that you're going to see a lot of problems down there. So the original equation of force equals mass over acceleration. So that mass issue is the big thing, right? So the ankle joint bears a force of 5 times your body weight just in standing, okay? 5 times. And if you think about how small your ankle joint is, it's tiny, right? It's not your knee. Your knee is big, your hip is big, and your hip and your knees are bearing, you know, this much weight. That talus bone or that ankle joint, which is literally smaller than your fist, is bearing the weight of 5 times your body in stance. And then when you're running or when you're doing something strenuous, it can go up to 13 times. That's a tremendous amount of stress. And that oftentimes is what contributes to people having chronic or long-term problems with that ankle, because if you have an injury to that joint or you have an injury to the cartilage or to the bone or anything like that, think of all that stress that you're putting through it for the rest of your life, right? You can't get away from that. And so that kind of chronic irritation or chronic injury is going to cause problems long-term wise. So again, tough issue. So what happens when you injure it, right? All sorts of things. You can break your ankle, you can roll your ankle, car accidents, slips, falls, sports injuries, all of that. So this is kind of where I get into the injury side of stuff. Again, we haven't, you know, talked for too long. Is there anything in particular you guys want to talk about? Anything in particular you want to get into more detail with? Or I could run through these slides real quick and we can do that on the tail end. What do you guys think? Preferences? Well, let me roll through them, okay? And then we can go into any of these details. So ankle sprains, extremely common, right? Happens all the time. 23,000 people a day require medical care for an ankle sprain. That is a tremendous amount. Typically what happens is that when the ankle comes down, you invert the ankle, which in essence is you're rolling that ankle to the outside, right? And when you do that, you can see on this picture is that the ligaments on the outside part of the ankle, they get stretched to the point where they obviously tear. And that's what an ankle sprain is. And those tears bleed, they hurt, they can bruise, and they can cause debility. So those 3 primary ligaments there, you can see the 2 in the red, and then there's the one in the top called the anterior inferior tibiofibular ligament. That's the 3rd one that's pretty critical. High ankle sprains are a little bit different. You hear of a sports injury of a high ankle sprain. Well, the ligament in between the shin bone, the tibia, and the fibula, the little ankle bone on the side, there's a big ligament in between there. And if there's enough energy, when you roll that ankle over, that energy not only will tear these ligaments down here that we've got indicated in red, but that ligament in between the tibia and the fibula will also tear. And that is a very critical ligament because it holds those two bones together. It allows a little bit of play in between those two bones. But when you tear the ligament, if those bones separate, that's the problem. And so those high ankle sprains are a little bit different. They need to be treated a little bit more aggressively or more cautiously. And so that comes into play. So treatment, RICE, right? That's what you do for practically everything orthopedics. You rest it, you ice it, put a little compression on it, try to get the swelling down, try to elevate it, and then you take some non-steroidal anti-inflammatories, calm that inflammation down. You can brace it with an ASL. If you've got a mild ankle sprain, something that's, you know, fairly self-limited, the patient can put a little bit of weight on it, you could probably get away with a little brace. If it's more severe, if it's something that's really swollen, really bruised, the patient's struggling to get around, maybe you have a suspicion of more of that high ankle sprain, then a boot's going to be a little bit better. It's a little more rigid, a little bit more support. It's going to immobilize those ankle ligaments that are torn, right? Because if you're tensioning on those torn ligaments over and over again, it's going to hurt. It's going to have a difficult time walking. And so you want to immobilize those ligaments for a period of time, get them to settle down, and then you want to actually start moving them again in physical therapy. It's been very interesting. A study that was done out of California, where Dr. Jana has a lot of his studies coming out too, that looked at Achilles tendon ruptures. And the studies showed that early range of motion of Achilles ruptures, so if you tear your Achilles tendon, the faster that you start moving those Achilles, the tendon actually heals with more normal tissue. Which is quite remarkable, right? You would think that if you're moving it or you're pulling that tendon apart earlier in rehab, is that it maybe wouldn't heal as good. But the studies are very clear that the tendon quality is better if you move it. And so we extrapolate that out, let's say to ankle sprains, right? An ankle sprain's a torn tendon or a torn ligament. And so the more motion you do, you're going to prevent stiffness, but also we feel that the healing of that ligament is going to be more normal tissue. Ankle sprains typically last 4 to 6 weeks. So ankle fractures. So if the energy that's put through that ankle is more than just enough to tear the ligaments, well, you could break the bone. The Logie-Hansen classification is a fantastic classification that really helps you to understand the mechanism of injury and why they break in the way that they do. But again, just more energy. The Weber classification is kind of rudimentary, still use it, you know, basically. But these are the kind of the types of ankle fractures that we see. Again, JBJS, long time ago, 1976, showed that the talus, which is that ankle bone in the middle, if it's displaced even 1 millimeter, 1 millimeter, so small, that it reduces your contact surface area 42%. So that little talus bone is so customized to each individual, it sits in that ankle mortise perfectly, and it's just meant to be there. And so any little shift of that talus bone, it messes up the contact surface. And so now you're going to start wearing out certain areas of that talus faster. And if you're wearing them out, that's arthritis, right? You're wearing away that cartilage. You're starting to wear away the bone. And so ankle fractures, typically, if they have any displacement of that talus, typically need to be fixed surgically. If there is no shift of that talus, then we can treat them non-operatively. So treatment, again, it depends, right? If it's minimally displaced, if it's stable, you treat with immobilization. You can even weight bear. But if it's an unstable fracture, so for instance, lower left, you have both the fibula broken, and then you also have this medial malleolus broken, right? Well, these are the two walls or the buttress of that talus. So if you've got both areas broken and they're unstable, this talus is allowed to move. And we already talked about if that talus moves 1 millimeter or more, you are messing up that contact surface area. You cannot have it. And so typically for those types of unstable ankle fractures, you're fixing it operatively. This middle picture here, this is a good example of this bone over here isn't broken, but the fibula is broken on the outside, and we have torn the ligament on this side. There's a deltoid ligament that attaches to the end of this bone and attaches to the talus bone. And when you have enough energy, you tear that ligament and it shifts the talus over, and we can't have that. So that would be something that would obviously warrant an operation. So all of these things are what we look at when a patient comes in with an ankle fracture. We're assessing all these little tiny things and determining whether it's stable, non-operative, or whether it's unstable and needs surgery. If you have surgery, you're putting in plates and screws like this, you're putting that bone back together perfectly where it belongs, you're fixing the fractures, holding them in place, so that number one, the bones will heal, right? We need the bones to heal. Those plates are not strong enough long-term wise. You have to have the bone to heal. But then the key is you have to fix the bones strongly enough, and this is general orthopedics. You want to have enough fixation to hold the bones in place that they heal so that you can start range of motion, right? Because you do not want these joints to get stiff. Big injury, a lot of bleeding, a lot of ligament damage. If you hold this thing still for 3 months, sure, it's going to heal, right? But it's going to be stiffer than a board. So you want to be able to stabilize the fracture well enough to where you can get that range of motion going, because if they're stiff, they'll have debility. So you've got to try to restore that normal anatomy. Surgery, typically non-weight bearing, 3 to 6 weeks, again, allowing that bone to heal. Cast, cam walker, physical therapy, again, is important. Patients can do it themselves, or they can attend, formal physical therapy. Swelling is a big issue. Swelling takes forever. It's dependent, right? It's the last in the totem pole. The vascularity down there is poor. The lymphatics are small. And so when you get swelling because of an injury, your little tiny vascularity down there doesn't have the surface area or the pressure to go against gravity and get that swelling out, right? And so you're going to get this pooling of swelling forever. And that's certainly frustrating for patients. It can cause, pain, again, debility and stiffness. So this is kind of the next level up from an ankle fracture, right? This is a Pilon fracture, which is an injury to the articular surface of the ankle joint. These are, again, higher energy, people that fall from ladders, people that get car accidents. These are oftentimes multiple fracture lines that go into the joint space. And as we discussed, when that joint space is damaged and that cartilage is damaged, you're putting 4 to 13 times your body weight through that joint. And so when that damage is done, that oftentimes leads to debility. So the goal here, of course, is that we want to try to get that joint line reestablished perfectly so that there is no friction, so that that ankle can move without any significant inhibition. CT scans are oftentimes important to determine what we need to do surgically. So treatment, initially stabilize that fracture. Oftentimes the skin quality is very poor. You don't want to operate through that. So sometimes we'll put on an external fixator for these, let the tissue settle down, and then go back 2 weeks later when the swelling's better, skin's better, and fix it. Again, plates and screws, holding it still so that we can try to reestablish the joint line and then try to reestablish that range of motion as fast as we can. Again, non-weight bearing, letting the bone heal, swelling, long time, pain, and again, long-term arthritis. Heel fractures. I love these. These are great. So these are high energy. Again, the heel is a very strong bone, but it's not like, when you take a stick and you bend a stick, well, it breaks in the middle, right? So your ankle fracture, you've got this long fibula bone, you've got a long tibia bone, and when those break, they typically break in the middle. Well, a heel bone, it's more like a cube. And so you don't snap a cube in half, you crush it. And so when you hit the ground with your heel, or you get in that car accident and your heel slams into the brake pedal or to the floorboard, you are in essence blowing apart that cube. So it is not one fracture, it is blown apart. And here's an x-ray top right and then a CT scan of what happens. So you get this axial load down in this cube and it just crushes it. So again, bottom left picture, you can see this talus bone right here is impacting down into the calcaneus bone, and it's just crushing everything else in its path. You can see these fracture lines. Here's the joint right here. And so we want to reestablish that joint line and get it up and get it as perfect as possible. So calcaneus fractures are a very painful problem. You can see the amount of swelling and bruising that this is almost every calcaneus fracture that happens. They look like this. They look terrible, and they're very painful. So surgery, again, you can stabilize the fracture. We want to get range of motion going. Recovery, again, non-weight bearing 6 weeks. You're seeing kind of a theme there. Casting, physical therapy to get that motion going, swelling, pain, etc. Same thing. So switching gears a little bit. So now we're going to go a little bit more to deformity. All right. So deformity comes in many different variations. This happens to be a flat foot deformity. Flat feet can be congenital, which is oftentimes the case. Most people who are flat foot are genetically predisposed. You're born with it, right? Maybe you've got a mom or a dad or an uncle or someone who's got a flat foot. And it's the way that your bones form is what drives that foot a little bit flat. Acquired flat foot is when people actually injure the tendon called your posterior tibial tendon on the inside. And if that tendon is injured and it can't maintain the arch, again, that Roman arch, then that Roman arch will flatten over time. Because again, all that body weight pushing down on that arch flattens it out. So two different times of flat feet. We call hindfoot valgus, this B picture on the bottom. You can see the straight line going down the leg and the calf when it hits the ankle. When that heel sticks out to the outside, that is called hindfoot valgus, and that is not normal. This patient's right side is pretty good, right? You can imagine a straight line down the middle. It's pretty straight. So this patient has a acquired flat foot because of likely their torn posterior tibial tendon. So here's the anatomy of the flat foot deformity. So we've got your posterior tibial tendon running right here. It comes down and hooks onto this navicular bone. This navicular bone is the Roman arch. This is the keystone to the Roman arch right here. And so when this navicular loses its support, either with this tendon being torn, holding it up, or with what's called the spring ligament, which is down here, you can see this spring ligament, then that Roman arch starts to collapse and you end up with a foot that looks like that. So that anatomy is what we try to restore back with surgery. And we try to restore that tendon. We oftentimes will replace that tendon with one next to it. And then we'll try to repair that spring ligament as well, trying to restore the arch. Oftentimes that hindfoot valgus, again, you see how it's kicking out to the side. If we're going to do surgery, we want to correct that, right? When that foot kicks out to the side, you're putting more strain on that posterior tibial tendon. You're putting more strain on that spring ligament. And so you need to cut the heel bone and shift it over. You want it to be the more normal alignment. So you have to cut the heel bone, slide it underneath the foot so that you're not putting that extra strain on the things that you're repairing, because that's what's going to help it last long-term wise. So there's the tendon in the middle. You can see how kind of thick it is. It's sick. It's not good. And then here's that tendon underneath. It's much smaller, but it's a great little tendon that we actually steal, and we cut this bad posterior tibial tendon out, and we put this new little tendon in its place. This picture on the right over here is kind of a new technique where here's that tendon transfer that we've done, replacing the bad posterior tibial tendon. But this complex here with this suture is actually repairing this spring ligament. That spring ligament gets stretched and torn when you've got a flat foot for a long time. And so we pull that foot over and we replace that torn tendon with these implants here. And that has had good success, both nationwide, but also in my practice too. Yeah, non-weight bearing therapy, certainly important for this one. Sometimes pain. All right, so going down in the foot, bunions, right? Everyone's heard of bunions. Bunions are also oftentimes congenital. We often think of bunions as, well, I wore, too small of shoes as a kid, or I've been wearing high heels all my life. That really has been debunked philosophy for about 25 years. We think that bunions are very oftentimes congenital. There's a genetic predisposition to people that get bunions. And if you kind of look through your family history, you'll probably find someone with a bunion if you've got a bunion. So what a bunion is where, in essence, the first metatarsal, so this bone right here, is not parallel with the other ones. So look at these metatarsal bones. See how they're all parallel? They're all sticking, in essence, in a straight line together. Well, look at this thing. It's way off, right? And these little bones on the bottom are called your sesamoids. You have tendons that attach to those sesamoids that then go out to the toe. Those tendons are pulling the toe back over, right? So if this bone is going this way, the tendons are going to pull the toe that way, and that's going to make the foot look like this. And that's what a bunion is. And so you can't correct this deformity with bracing. You cannot correct it with toe spacers. And sure, toe spacers can help prevent your toes from rubbing, and that can cause pain or whatnot, but you cannot fix this deformity without fixing the bone. And so oftentimes bunions require an operation to truly fix. The only non-operative treatment for bunions is bigger shoes, right? Wider shoes, things that don't rub on this big bump over here. So most people choose surgery, and of course, the goal of that operation is to realign this bone parallel. So look at how nice and parallel this is to that second metatarsal. That's what you want. Hammer toes. So hammer toes are a deformity of the toe. This little joint right here called the PIP joint, the flexor tendon gets tight and it starts to curl that toe down. And over time, if that joint is stuck in that fashion, it will remain stuck. So some hammer toes, you can physically straighten them out and then they'll kind of curl back. Some of them, if they've been that way for a long time, they're fixed. You can pull on them all you want and they will not straighten out. And those are ones that, again, you cannot fix that unless you have surgery. So bunions, hammer toes, obviously very common in the foot and ankle world. We see a lot of debility. Of note, and we can go back to this in a little detail if you want, but bunion surgery, there are 1,000 different ways to fix bunions. It is always, a question of patients that come in is like, well, what do you do? How do you do it? And there are multiple different ways. Each one of them has their own advantages and disadvantages, and we certainly could talk about that if you guys want at the end. So arthritis, we talked about all those little joints in the foot, right? All those little joints can get arthritis. So it just predisposes itself to having a lot of arthritic conditions. You can have ankle joint, subtalar joint, midfoot arthritis, big toe arthritis. So what do, right? Well, in the total joint world, you replace it, right? If you got an arthritic total knee, you put some metal and some plastic in there and away you go. You're doing great. Well, these joints are so small, and again, they take so much body weight, so many Newton force on these things. Replacement oftentimes does not work well in the foot and ankle. Ankle arthritis has been the one joint that we have found good success with ankle replacements. So fusion has been the gold standard for many, many years. Fusing it is basically growing those two bones together, making it rigid so that it will last and be durable, but you lose that motion, right? And when you lose motion of your ankle, you are losing functionality. You no longer have normal gait mechanics. And although you can walk and you can get around, you can do okay, you're still losing something, right? And so if you can preserve those mechanics, if you can salvage that motion and preserve those gait mechanics, you would assume that that patient is going to function better. And then as long as you're eliminating pain, that's an advantage. So ankle replacement, certainly over the past 15 years, has really come back into vogue. The designs of the new ankle replacements are so much better than what they were back in the late 80s and early 90s. We had a surgeon up in Sioux City who's doing his own implant. He designed his own total ankle implant up there, and it was a horrible design. And him and his son were putting in a ton of them, and they're all failing. They would last 2 years, maybe 5, and they're all absolute disasters. And so total ankles in the United States got a really bad rap because they thought, well, they don't work, right? None of these things are working at all. Well, it was because of the implant design. Europe, in the meantime, was doing different implants, and they were having great success, but the FDA wouldn't allow their implants to come over to the United States without studies. And so my mentor, Mike Coughlin, and a bunch of his foot and ankle colleagues got together. They did the study that really got ankle replacement over the United States and has it much more utilized now and is now very common, and patients are doing much better. Survival rates are anywhere from 10 to 20 years on them. 20 is a stretch. It's tough to get 20 years out of them, but 10 years is pretty reasonable. So they do pretty well. Midfoot. So we can't replace the midfoot, right? Too small joints, too much pressure. So what do? Well, we fuse it, right? Those joints don't move much. It's not like the ankle. It's not like the big toe that has a lot of motion. So fusing those really does not give you any functional deficit. It really just gives you pain relief. And that's what most people are after, right? No one wants pain. The big toe, there are big toe replacements. They also don't work very well. They oftentimes fail. Again, tremendous amount of force going through that big toe. And so there are toe replacements out there. Quite frankly, what happens is podiatrists put them in, they fail, and the patient comes to me and I have to fix them. So I don't like them. I don't put them in because they don't last long. So again, in my hands, typically fusions are a better option. And again, although you lose some functionality, most people with toe arthritis are stiff anyway. And so if you fuse their big toe, they don't notice a difference. They're already stiff. What they notice is they have less pain. And so ultimately, they're pretty happy.
What factors do you consider whether you split somebody or put them post-op?
Post-op, biggest thing for me is a lot of the times if you're doing something with the ankle or you have an injury to the ankle, you oftentimes want to pull that ankle back to stretch their Achilles. Because what happens is that the Achilles is tight or the injury causes swelling and it plantar flexes their foot naturally, all right? And boots don't do a great job at bringing your ankle back and holding it. There's a lot of play in the boot. And so ultimately your foot can kind of plantar flex in that boot a little bit. And so if you are doing a surgery and have swelling and pain and they're not able to weight bear on it, which pulls the ankle back, you want to splint them because you can get total control of that ankle and get that Achilles stretched out. That's typically the reason.
Most of these surgeries outpatient?
Most, yes. If not, some overnight stays. Calcaneus fractures hurt like crazy. They tend to stay at least a night. Pilon fractures, big injuries, some bad ankle fractures. Total ankles typically stay overnight. So most of that bigger stuff, mainly around the ankle side, they usually will stay overnight. But most of the small stuff, forefoot stuff, typically that goes home same day.
Are you familiar with minimally invasive for bunions?
Yes, definitely, and I do them. So I was thinking about putting some slides in, but new technique came out probably 5 years ago. Really has been popularized over the past 2 years. Certainly has big advantages. So minimally invasive bunions are done through very small incisions. The bone is cut with a burr, which is like the smaller than a pencil. All right, so it's a very small instrument that you're utilizing in order to cut the bone. And then you're shifting the bone over with manipulation. And then again, through small incisions, you're putting your hardware, your metal in there in order to hold it to position. There are, again, advantages and disadvantages like everything. I think some of the smaller bunions don't do as well with the minimally invasive because smaller bunions, most people are complaining of the bump, right? And that bump, if we go back, that bump has right here has the ligament, big ligament on it. And this big old bump that causes the pain, it's hard to shave that bump off with the minimally invasive technique because what you're doing is you're kind of stripping that ligament off and you need that ligament. It's important. It's stabilizing the toe. And so if you can't shift the toe over as much, let me go back to that bunion. So what you would do is you would cut the bone here. Everyone see that okay? You're cutting the bone here and you're shifting this entire metatarsal head all the way over. But you cannot remove this bump easily through a minimally invasive procedure. So as long as you're shifting the bone way over, this bump will go away, right? Because it's going to be in line with this bone. You're shifting it all the way. If you've got a more small bunion and you can't shift this metatarsal head over as much, they tend to still have that bump, and they don't like that. So it's a great procedure for some bunions. I think that selection, I do think, is a little bit important. But it's less swelling. It's a little earlier weight bearing, which is an advantage. The healing has been shown to be pretty successful because you're not stripping all the soft tissue, right? When you do an open bunion procedure, you're kind of taking away all the blood flow or all the blood supply to that bone, and then you're cutting it and you're asking the body to heal that bone where you just stripped all the blood, right? Well, it takes longer. It happens, but it takes longer. That minimally invasive, you're not stripping all that tissue. You're just using that burr. And so they think that the healing is a little bit faster, and it probably is.
Do you always use hardware with those, or do you just put them in a splinter and let them
hardware.
Always.
Yeah,
perfect.
always. Yeah, because that when you cut this thing, so when you're cutting this bone, it's unstable. And especially in the foot, right? If you're standing on it or you're putting any pressure on it, it is going to shift or displace. So you got to put hardware in
K-wires or plates or
it. Screws. No plates, just screws. There's another minimally invasive procedure out there called the Lapiplasty. It's kind of that's actually what this X-ray is a Lapiplasty, where you're actually fusing this bone back here and correcting your deformity through it. It's a fine procedure. It's done through kind of minimally invasive stuff, but there can be complications to that too, just like anything. But yeah, minimally invasive. It's the way of the future. Not only is it being used for bunions, it's being used for, remember we talked about in that flat foot, cutting that heel bone and shifting it over. You can do that minimally invasive. You can do hammer toes minimally invasive now. So minimally invasive is really taking on in the United States. It's been around in Asia for about 20 years, and they really have, I'm not going to say perfected it, but they've worked out a lot of the kinks. You know, for whatever reason, their patients are more tolerable of mistakes over there. And so they've really refined the technique as to how to optimize the surgery and how to optimize the recovery. And so they've really given the United States a tremendous amount of information on minimally invasive surgeries, and we've learned from all their mistakes. So certainly more to come in the future on minimally invasive.
There's a couple questions online. I'll read them to you. If you have a deformity of the foot, at what age should this be done, or is it more pain-driven?
Usually more pain-driven. Most deformities in adolescence that people get concerned about are flat feet. If they see their kid walking around and their feet are rolling in, or toe walking, which is the opposite. Kids are always up in their toe. In kids, it's amazing is that as their bones are growing, they change. And so we will oftentimes see kids that have flat feet, maybe at the age of 4 to 6, that will grow out of it in 2 to 3 years, which is quite remarkable, right? Those bones are growing such that it pushes them back out of the deformity. And so, you want to give them supportive shoe wear and things like that. But if the child isn't having a lot of pain or discomfort, I would not recommend taking them in. Pain or discomfort, obviously different, right? That's something that you'd want to get evaluated because there may be something else going on or something, something that needs more assessment. But for the most part, if it's just deformity, you're not going to change it because, like we talked about, it's genetics, right? Your genes are driving the boat, and if you put them into a good shoe, that's all you can do. You're not going to change Mother Nature. She wins every time. So I would really go on pain or any functional loss would be the time at any age.
Someone asked if you would quickly describe speed bridge Achilles tendon injury, aka Aaron Rodgers, and also tightrope procedure for high ankle sprain.
You bet. So we'll go with the speed bridge. So Aaron Rodgers tore his Achilles. You have your heel bone, right? Your calcaneus in the back, and then your Achilles tendon. Thank you so much. So this is looking directly at the heel from the back. Okay, so you've got your heel bone, your calcaneus is like this, okay? And then you've got your Achilles tendon that comes down and it attaches to the back of the heel bone, right? So calf muscle is up here, okay? So Aaron Rodgers, Kobe Bryant, Kevin Durant, all these people, they have ruptured their Achilles, so they've torn it. And what happens is it's not like a nice clean cut. When you tear your Achilles, it's like mop ends. The Achilles has strands of ligaments or tendons that are coming down. And when those things tear, it's like 2 mop ends flapping in the breeze. Okay, it's a mess. And so what the speed bridge technique is, which is what typically we all do, is that you put suture up through the tendon, kind of up here, and you kind of gather that tendon together. And you're doing this through a very small incision right over the Achilles. Again, minimizing trauma, minimizing blood loss. to the Achilles. You want to preserve all that blood flow. And then once you've kind of gathered up all this, you've got these sutures. And you pass those sutures under the skin all the way down to the heel bone. And through a small incision down to the heel bone, you pass these sutures out of the skin incision, okay? And then you, in essence, are pulling on those sutures to pull this Achilles tendon back together. You're reestablishing the tension. And then you're taking those sutures and you're drilling a hole in the bone down here. And with an implant, you put the suture on the end of this kind of screw, and you push that thing into the bone and kind of screw it in. And so it holds those sutures under tension that pull that Achilles tendon down where it belongs. Okay? So the speed bridge technique is, in essence, gathering the tendon with suture, minimally invasive, passing it down under the skin, and again, minimally invasive, plugging those sutures into the heel bone to reestablish that tension. And the beauty of that, again, is that it's minimally invasive. You are not stripping the blood supply. You're expediting the healing because you've got all your native anatomy around that tear, feeding it with the blood supply, feeding it with the ability to heal. And the suture that's utilized here is extremely strong, and so they feel that they can rehab faster, right? Again, professional athletes, college athletes, you want to get those players back in the field. That's their livelihood, right? That's how they make their money. And so the goal is to get them back as quickly as possible. And that's how you do rehab. So good, strong repair, early rehab. That's the idea. Will he be back this season? I doubt it.
They recover pretty well, though.
They do. Yeah, for the most part, they do pretty well. And the biggest complaint is that, those mop ends that you pull apart, you're pulling them back together, but they're still mop ends, and they heal with some scar. And so they're always going to have kind of a fullness where the tear was. And a lot of people, they don't like it. They look at this side and say, well, it's this nice little, rope, and this side's all bulky, but that's the price of doing business, unfortunately. The other question was the high ankle sprains. So
There's a follow-up question. Are the sutures removed after that surgery?
No, typically stay. They are permanent sutures. They do not dissolve. But again, that's part of the beauty of it, is it adds strength to the Achilles tendon in and of itself. So they typically are kept in. The speed bridge is typically used for ankle sprains or high ankle sprains. To go back to my anatomy picture here. So this ligament in red right here, called your anterior talofibular ligament, that is the most stout ligament of the ankle. And that's the first one that people tear when you get an ankle sprain. And if it's torn bad enough, or it's been torn so many times, so if this is your ligament that's really tight and you tear it and it heals like this, and then you tear it again and it heals like this, that tendon or that ligament is getting longer, right? And it's no longer serving its function. It's no longer tight, and so your ankle can rattle around or move around more than it should. And so what the tightrope is you are, in essence, reconstructing that ligament by burying an implant into the fibula bone that has that strong suture on it, and then tensioning it to the talus with that strong suture. So in essence, you are replacing this ATFL ligament, which tears, with this super strong suture, which doesn't tear. And so again, very strong, getting athletes back to play much faster, and of course getting patients back faster as well. Syndesmosis injuries, we talked about that ligament between the fibula and the tibia. High ankle sprains are a tear of that ligament. Well, you can put a similar type construct where you put a button on the outside and a button on the outside of the shin bone, and you pinch those together, but that rope, the suture, still has play in it. So again, it preserves the normal anatomy or the normal motion of that joint while still providing that stability. Tua, so the quarterback for the Miami Dolphins, I don't know if you guys remember, but when he played in the national championship for Alabama, the game before the SEC final, he had a complete syndesmosis tear. If you looked at his x-rays, his bones were separated by like a centimeter. It was unbelievable. He had this surgery done with that implant called the tightrope, which is similar to this kind of construct. And he played in the SEC championship and ultimately the national championship with an injury that was 3 weeks old. It was unbelievable. And of course, the company who made that implant made a big deal about it because they wanted to tout their product, but it was quite impressive. And it really just showed the world, certainly the medical field, that this implant's strong and allows early rehab. And I know the guy who did it, and he was showing me all the videos of Tua doing his exercises and stuff a week after surgery. It was incredible. It was incredible what he was doing and putting in the work to get back to play. Great study. So the question is talking about conservative treatment versus operative treatment on Achilles tendon repairs. And there's a great study that is done out of Scandinavia. And Scandinavia is different because all their patients are thin and relatively active and relatively healthy. So it skews the data a little bit. But they had a fantastic study in 2005 published in Foot and Ankle International where they took a huge patient population of about 550 patients in the operative group, 550 patients in the non-operative group, and they developed this rehabilitation protocol for both sides. And they said, all right, we're going to take half of these, 550 people, we're going to do surgery. They all kind of did the same thing. They opened, the Achilles tendon repair, similar to this. And then they went through the rehab. And then they took these other people that tore their Achilles and they did non-operative treatment, which consisted of a cast for a little while in plantar flexion, right? Because if you pull your ankle up, you pull that Achilles tendon apart. So you cast them in plantar flexion to pull that tendon back together. You get it a little bit of healing, and then you gradually build their ankle, pull it back up. And ultimately what it showed when they followed this certain protocol is that the outcomes after 2 years were the same. And those outcomes included pain and strength and functionality, okay? So ultimately, it's the same, right? So the question is, well, why are we operating on anyone's Achilles? Well, it's because it's America and people want to be better yesterday, right? They don't want to wait that long time. So the rehabilitation is a little bit faster in the operative group, and patients have a little bit higher strength early on in the operative group because they got the tendon together, right? But that really gets lost after about 8 to 10 months. Certainly in a year, those strength curves have normalized together. And the complications of surgery are obviously higher. Infection, right? So that was one negative against surgery. But the positive with surgery that the outcome study showed is that the re-rupture rate was substantially lower in the operative group. And that's because you've got suture, right? It's stronger. So that's the conversation I have with every single Achilles tendon patient I have and say, look, 2 years from now, you're going to be the same no matter what you choose. But if you have surgery, you're going to have a little faster recovery. You're going to have more strength early on, and you're going to have less re-rupture rate in the future. So those are the positives. The negative is you could have an infection. And that's it. And so most people that tear their Achilles are fairly active individuals. Most of them are tearing it, doing some sort of sport or some sort of activity, whether they're 50 down to 20. And so most people choose surgery, right? They hear about Aaron Rodgers, they hear about Kobe Bryant, they hear about Kevin Durant, and so most people do surgery. But I always have the conversation.
So I know some people that are pretty active, and one day the guy goes out to play basketball with his kid. First shot, boom, tears his ACL. Like, he's hiking mountains, he rides bikes. Like, is that like a genetic thing? He had no pain, nothing to make him feel like there was something wrong with his Achilles tendon. Boom, just tore.
We don't know.
Yeah.
We don't know. It's a great question because a lot of these individuals are super healthy, right? And why are they tearing their Achilles tendon? Look at guys like Kobe Bryant, arguably one of the best athletes ever to live on the planet. right? You wouldn't think that he would have any genetic deficiency in his body because he is such a high level athlete. He wouldn't be able to be that high level of an athlete unless he was perfect, from a tendon genetically. So we don't know the answer. And honestly, I don't think there is. We think that there is a genetic predisposition to what we call tendinopathies. So like rotator cuff problems or insertional Achilles tendonitis or tennis elbow, right? Those types of tendinitises, I think there's a genetic component to that. People are just predisposed to that inherently. But that rupture of the Achilles, I think, is just a freak thing where that sudden acceleration or deceleration, for whatever reason, it just puts so much Newton force right then that boom. So what it usually is when you're going from a relaxed state to a hyper-contracted state, right? And so, it's like if you are accelerating off, right? Your tendon is relaxed, and then you're making that quick acceleration to do whatever it is you're going to do. I think it's kind of like, think of it like a rubber band where the rubber band is almost too relaxed, and then you're pulling it really excessively. And it's kind of like that whiplash. It's just too much and it'll tear. Whereas if the tendon or the rubber band had been slightly pulled, right? If it was kind of already under a little bit of tension, and then you tensioned it more, it wouldn't have teared. That's my theory. That's all I
I
got.
think I've seen what method is that the guy was like getting out of his chair. He's like 50 something.
Yeah. So, again, we'd have to look at his whole body picture. I don't know, but yeah, some of them are just like, how is this possible?
Do you believe in those like bands, like go around the midfoot to try to change how it's pulling?
Yeah. So again,
sometimes you're put them here.
exactly. So it's the same concept as tennis elbow, is that if you're putting all the strain on the tendon right here in your elbow, if you're putting it's kind of like when you play guitar, you're putting your finger on the string, you're dispersing the tension on that band as opposed to putting all the tension on the painful area. And in theory, you're taking some pressure off of it. They don't really work in plantar fasciitis. Again, if one thing worked, we'd all be doing it. But none of it works.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.